All right. Well, welcome everyone. Thank you for joining us this afternoon for our joint Academy for Diversity and Inclusion in Emergency Medicine and Social EM and Population Health Interest Group webinar panel. The title of the panel discussion today is Advancing Health Equity in Emergency Medicine Through Community-Based Participatory Research. My name is Edgar Ordonez. I'm an associate professor at Baylor College of Medicine and the current president of ADIEM, and I'll be co-moderating today's session.
And my name is Payal Modi. I am an assistant professor at UMass Chan Medical School, and I am the co-chair of the Social EM and Population Health Interest Group, and I will also be co-moderating this discussion.
All right, so before we get started, oh, go ahead, I'm sorry.
I wanted to kind of start off by introducing our panelists that are on the call today. First, we have Christine Garoya as an assistant professor in the Department of Emergency Medicine at Yale University, the DEM Wellness Officer and the Director of Global Health Research. Her research interests center on non-communicable diseases, barriers to care, and community-based interventions with a particular focus on Africa. We're waiting. Dr. Talo Brown will be also joining us shortly. He's an assistant professor at Stanford University and leads the Health Equity and Social Justice curriculum. He has worked with as the Chief Impact Officer of Trap Medicine, a barbershop-based wellness initiative that leverages the cultural capital of barbershops to address the physical and emotional health of Black men and boys. Next, we have Mackenzie Yor. She is an attending in the Greater Los Angeles VA Medical Center and is a current fellow of the National Clinical Scholars Program at UCLA. Her research interests include partnering with patients and communities in research and co-creation of the health-focused interventions, healthcare design, patient clinical communication, and the intersection between urban planning and the environment and public health. And finally, we have Dr. Vidya Eswaran. She is an assistant professor at Baylor College of Medicine and the Center for Innovations in Quality, Effectiveness, and Safety at DeBakey VA Medical Center. During her time at UCSF through the National Clinical Scholars Program, she worked with the Rafiki Coalition for Health and Wellness, a community organization whose mission is to eliminate health equities and inequities in San Francisco's Black and marginalized communities. We're excited to have you guys today. Thank you so much for joining us.
All right, so before we get started, I just wanted to bring up some logistics. Today's session is going to be recorded and available on the SAM website in the near future. And I'm going to start this session by providing a very brief overview of community-based participatory research, and then we'll follow that with our panel discussion. After we have our discussion, we'll have a moderated Q&A session. So please feel free to drop your questions into the chat box anytime throughout the hour, and we'll attempt to get to as many questions as we can at the end. The slotted time for the actual discussion is till the top of the hour, which is 3 p.m. Central Standard Time, but we actually have an extra half hour at the end if we need to have extra time for detailed Q&A. So just be aware of that. All right. So I wanted to start with a definition of community-based participatory research. And this is just one of the few definitions that was obtained from the Kellogg Foundation, which is a postdoc program, and basically reiterates what some of the other known definitions describe. CBPR is a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. CBPR begins with a research topic of importance to the community and has the aim of combining knowledge with action and achieving social change. So briefly, I wanted to show this diagram, which is relevant to what we're going to be discussing today. And it basically shows what's considered the continuum of community engaged research and how there's a distribution of involvement and power as we see it across a continuum from communities. And I think that discussions on CBPR and other forms of community engaged research at this time are really timely. We've witnessed the continued health inequities that exist in our communities, many of which are a result of the structural drivers of health. Many of you have been involved and are aware of SAM's last two consensus conferences, the Social EM conference in 2021, and then this past year on addressing racism in emergency medicine. And as both of these conferences set forth their agendas, their research agendas, the importance of building local community partnerships was definitely discussed. So, it's important for us to realize that many of these communities have resources that us as researchers or potential researchers may not be aware of. And then there's, the concept of trust. It's a big difference when you're doing research with communities instead of just doing research in communities, and that in itself builds trust. Now, this last slide is basically just a list of what the principles of community-based participatory research are. It's also important to consider, though, what CBPR is not. So it's not just community-placed research, as I showed in my last slide. It's not just sporadically including communities, and it's also not doing a specific research method or research design. But if you look at some of the wordings that are used in the principles, several of these words, stand out that are important in the conversations that we're about to have. One, obviously, is community strengths and resources, collaborative and equitable partnerships, balance between research and action, promoting co-learning, capacity building, systems development, local relevance, dissemination of findings, and long-term commitment. So now that we've kind of had this brief little overview, we're going to move on to discussing, with our panelists today and hearing from their experiences. And again, the goal of and I'm sorry, I'm going to stop sharing this in a second. And the goal of our discussion today is not just to learn about CBPR, but we want to do it in the context of their actual experiences so that we can all get a feel of some of the things that we can do as EM physicians in this space to advance health equity. So I'm going to start the first question. We're going to ask Dr. Eswan. Now, we're going to ask that all panelists answer this specific question because it's really relevant and allows us to hear your specific experiences. But first, Dr. Eswan, tell us about your journey into exploring CBPR as an approach for your research. And within your discussion, give us an example of a project that you've worked on and how you've defined community within that project.
Thank you, Dr. Ordonez, and thank you so much for having me on this panel. I first became exposed to CBPR as a concept during my fellowship. I, like Mackenzie, was a fellow in the National Clinician Scholars Program, and I was at UCSF. And CBPR was something that we received lectures on and was highly encouraged for us to participate in the limitation of it just being a 2-year fellowship and understanding that developing relationships with community really takes time and longitudinal effort. And so we really focused on capitalizing on relationships that already existed with mentors at the institution to identify a community organization called the Rafiki Health and Wellness Coalition in San Francisco, which was started during the AIDS epidemic, but continues to provide a lot of healthcare resources and specifically mental health care resources for the Black community in San Francisco. And we, I think, initially started on the left side of that diagram you showed, where it was really investigator driven. Our project, which we're continuing to work on, is on disparate use of restraints, physical restraints in the emergency department amongst Black patients who come to the ED at the 2 UCSF affiliated hospitals. And we started out with a question in mind and presented it to the community organization and said, what do you think of this project? And they really encouraged us to reframe the way we thought about it, to really think about how we can make this a more patient-centered approach, as opposed to just saying, hey, here's a problem, how do we fix it? And turn it more on an inward look into the hospital setting. And so really had to shift from kind of what was traditionally taught of present a problem and find partners to get you to answer the question, to more let's reframe exactly what the question is to start before we get too much deeper.
All right, great. Well, thank you for that answer. And I think that what you made clear there is that sometimes we have to have a sense of reflection to understand that the issues that may seem important to us aren't necessarily as important to the community or at least not prioritized. And that's why, this approach definitely is important in kind of advancing this work. Dr. Yor, I'd like to ask you the same question.
Sure. Thank you so much for having me. And I'm excited to learn from the other participants and share a little bit about our work. So I'm a second year fellow at UCLA in the National Clinician Scholars Program. And years back when I was thinking about specialties in the area of medicine I wanted to go into, I chose emergency medicine in part because I really wanted to work on emergencies that were in some way preventable and trying to work upstream at the community level to prioritize what some of those issues might be, and then work in partnership with communities to address the health issues they thought were most important. And then as I advanced in my education journey and was looking at fellowships, the NCSP really prioritizes CBPR as a methodology, and we get a lot of training in it, and there are community partners that are established and have worked with fellows for many years. The particular project that I'm working on actually was a partnership that was just starting as I was leaving residency. I went to emergency medicine residency at UCSF Fresno, and our residency was developing some connections with the Department of Public Health there. And one of the issues that the Department of Public Health wanted to address was the health effects of climate change in the Central Valley, which we could all, really feel in our daily lives, and then also see the health effects of climate change coming in as manifesting in all sorts of ways, from heat-related illnesses to exacerbation of chronic disease to mental health issues. So the Department of Public Health thought that this was important and wanted to address it in a community engaged way. And we're still at the beginning stages of that journey. What we started to do was assemble our partners. So we didn't have just one partner, we have at least four. There's the Public Health Department, the Central California Environmental Justice Network, the Public Health Institute. There are academic partners like me, and then several residents who are at UCSF Fresno. And we put together a proposal for a grant through the California Resilience Challenge funded by Bay Area Council. And they were hoping to fund community-based projects like this one on really anything that you wanted to do to build resilience, environmental resilience in communities. So we proposed to do a climate change and health vulnerability and adaptation needs assessment, and go about that in a community engaged way. So it didn't really start out as research as much as it did a community assessment, but we're embedding research into that. And we use a number of the tools that are commonly used in community-based participatory research, like a community advisory group, and trying to gather input from the community in our processes, both for the needs assessment and for the research arm. And I could talk more about that later on in the session if there's interest.
Okay, well, thank you so much for sharing that. And I agree with what you mentioned. Is a lot of times when we're considering these types of approaches, folks don't realize that public health interventions are also a way to connect with communities, engage with communities, and be able to show outcomes. So the research part is definitely about putting together something that will show positive outcomes, but folks need to also consider this as potential public health interventions for our community members. Dr. Oroya, I'll have you answer the question now.
Awesome. So thanks again so much for the invitation. It's truly an honor to be here with you all. And I'm excited to be here talking about this topic, which I think, at least for me, is something that we can all incorporate in our projects, QI, research, in various ways. So I think that hopefully the points that we disseminate today, you're able to think about how you would use them in your
Looks like she froze for a minute there. Okay, well, we'll come back to Dr. Goroya in a second while she sorts out that connection issue. I'd love to hear from Dr. Brown. How are you doing?
Not bad. Can you hear me okay?
We can hear you fine.
All right, excellent. Thank you for having me today. And it's just inspiring to hear everybody's personal narratives, because to be quite honest, anytime you're working in this space, sometimes it can feel lonely. It can feel like you're doing work that doesn't have as tight of a knit community, because the messages don't often blend across the space. So it's just incredibly powerful to hear this. I initially started, again, out before I was even in medical school. I was working in community-based participatory research. Began doing barbershop-based health initiatives around probably 2010, 2009. And eventually it kind of took shape along with a brother of mine. His name is Jamil Lacey, who I went to college with. He lived down the hallway from me at Morehouse College. And we both had a similar interest of wanting to affect change in the communities that we came from. I'm from Sacramento, California. He's from Oakland, California. Eventually, he developed the moniker TRAP Medicine, Trust, Research, Access, and Prevention. And I just remember going through public health school, learning about needs assessments, and making sure that from the very outset, our goal was to center community needs, not to assume we knew what they needed. And that was very organic for us. The interesting thing about Black barbershops is that these are safe spaces, and have traditionally been they would be like the country club for Black men. And it's a very unique environment, one where you can talk about anything from who's the best basketball player to where's the best place to get food in the city, and even like how to use a condom. And so growing up in barbershops and hearing these conversations and realizing that this is very interesting space to be in and to be invited into, trying to use that space in a different capacity was the challenge. It involved a lot of conversations with barbershop owners, barbershop participants, people who practice barbershop culture, as well as public health minds. And so through the time that I was training in residency in the Bronx, I experienced a lot of failures going into barbershops, people laughing me out, and working through those challenges with Jamil eventually landed us in barbershops in Oakland and Los Angeles. But one of the greatest lessons I learned is just because I was Black didn't mean that they were going to accept me and accept this conversation. It had to start with identifying the community leaders, community pillars, and figuring out like the landscape of these barbershops and really what resources they needed. And a lot of it came down to educational empowerment, came down to having better relationships with the healthcare system and kind of correcting some of that mistrust. So an element of restorative justice had to occur. And these are things that you take on when assuming to do this type of work, particularly with a community that's often marginalized and typically told that they are voiceless. And so now where we're at is essentially operating a standalone or working through a standalone barbershop in Los Angeles, California. And we've done everything from COVID screening all the way up to colon tests, and have led into being a hub for other resources like where to get, where you can take the GED, where you can find food pantries and clothing pantries and things like that. So, but I just want to again reflect that all of these lessons are cumulative, and it's not something that you can go into it knowing exactly how a community is going to respond. You can't assume that they're going to automatically accept you just because you come from it or because you may have a similar characteristic.
All right. Well, I thank you so much. You and I have had this conversation before, and I think one of the, things that you brought up is it holds true here is building that relationship of trust, and that can take time, obviously, and for many of a researcher, it's like a time of sacrifice, because the way that medicine has been hierarchical over the years, and academic institutions, medicine, sometimes it's difficult to let go of that power, which kind of lives innately. But in order to be effective in these community health interventions or community-based participatory research, we have to be willing to relinquish and share that power in order to be effective in what we do. So I appreciate you bringing up that topic. Dr. Goroya, I'm not sure if you were able to
Yeah,
join us
I'm
again.
I'm
Okay,
gonna try again. What I failed to mention is that I am out here doing the
okay.
participatory thing. I'm in Africa, so the connection is not great. But I'm gonna leave my video off to save some of my bandwidth. What I was gonna say as
Sure.
far as my story, or sort of one of my big takeaways, is exactly I think what you just mentioned, Dr. Ordonez, which is that at first, as was mentioned by Dr. Aswara, it can come across as being difficult in terms of performing CBPR or community-based research, building those relationships, enforcing those relationships, and implementing the recommendations you get from the community. However, it is necessary. And I think that's part of Dr. Ordonez's point. The most sustainable things, interventions, programs, or projects I've worked on have been participatory in nature. And I think if there's nothing else that at least you take away from me, that is my takeaway for today. How did I come into CBPR? I actually went to medical school where there was a family practice physician who offered an elective. So my journey started about more than 15 years ago. I did this elective, read some of the core articles, like was shown, the Israel Schultz paper, several other Israel papers that we'll probably share after this session, from what I understand, and was already engaged with this population, this refugee population in my community. And we went about, I went about spearheading along with partners in the community, including community-based partners, i.e. Refugee leaders at various community centers and various other communities at my church, etc., as well as other partners that I can talk about a bit more later, or key stakeholders, as we call them sometimes. And that program is still in existence, again, like 15 years later. It's been adopted and implemented into the service learning program for the university. A more recent program that I'm super proud about, and I think is something that may also be a takeaway for us in EM, is a homeless population or housing insecure population targeted intervention or program that's based at our university, started as a resident project now 6 years ago, and has continued to sort of be passed along by various resident leads. We just published a paper in 2021 on some of the milestones that CBPR can achieve, ACG milestones, if implemented in residency programs, if implemented as a research opportunity or a participatory research opportunity. And now it's a task force, hospital-wide and community partnership task force with people with lived experience. Again, happy to share more about that if there's interest. And also happy to share the link for our paper if anyone's interested in that later too. Thank you.
All right, well, thank you also. I wanted to kind of make a comment about something that you mentioned in your exposure to CBPR. And it's sort of being unfortunate that many of us in the medical field don't get exposed to it earlier on in our training. I know that I think almost everybody that's in this panel has an advanced degree in either research or public health. So, that potentially has provided us with the exposure or experience and potential mentorship in this space. But for many of us, we don't. And I think it's important to ensure that medical education, and I know that we discussed this during the consensus conference this past year in addressing racism in emergency medicine, is that we look for community level interventions, that we look for community data, but involve our community members in obtaining that data and do this work to really advance health equity. But I definitely think it needs to be something that we need to focus on in medical education to get early exposure to our trainees. Because to be honest, had I been exposed to this a little bit earlier in my medical training, I definitely feel it's an approach I would likely use more often. So, all right, well, we'll go on to the next discussion point. And in talking about community partners, I wanted to get an idea from a few of our panelists. I'm going to ask Dr. Eswarn if she could answer this question. What do you feel are some of the characteristics of effective community partners? And what are also characteristics of being good partners ourselves with the community?
Sure, I can speak from my experience, and I think humility and shared vulnerability was really important when we were developing these relationships. There's a lot of mistrust of large academic medical centers amongst the communities that many of us really want to make an impact with, and from where our community organizations and partners are coming from. And so, it took the first 6 to 8 months of our relationship where we went out to their community site, we shared meals, we got to know each other personally, we learned about families, backgrounds, children, and developed those types of relationships before we even really started talking about our project and our aims and our goals, because we needed to build that trust in that relationship. With that, we are able to call each other out when we disagree, or if I say something that doesn't fit well with the community's thoughts, or if I'm making assumptions that I shouldn't be, they feel very comfortable in calling me out. And I also feel comfortable in trying to explain what happens in emergency departments and why, yes, ideally we wouldn't be restraining anybody, but sometimes we have to, and trying to explain that. And I think it's only because we had that relationship building that happened before that we feel comfortable having those types of conversations. It was really helpful for us to also work with a community partner who's had some experience working with with medical institutions and with researchers before. Because they kind of have gone through this process. And so that was helpful, especially as a fellow and trying to finish a fellow timeline style project. That was helpful for us as well. And then really tried to recognize that the community organization we're partnered with doesn't necessarily represent every Black person in San Francisco who may show up in the emergency department. And so worked with them to kind of identify where the gaps in their outreach may be, and to try to identify other folks to fill in those gaps. And I think that also came back to having that trusting relationship in the beginning to be able to make those connections as well.
Okay, well, thanks so much. I wanted to reiterate that point that you made about humility, and also add on how sometimes it's difficult how we are able to create safe spaces for people too, that are responsive to their needs. You know what I mean? These communities' needs also. I'm curious to hear from Dr. Brown. When we've previously discussed barbershop medicine in the past, I felt that this was a type of intervention that would be definitely an area of potential impact for our community, specifically in the community that I work in. How do you, again, as I asked Dr. Eswarn, how do you define what an effective community partner is? How do you know where to go? Is it just like trial and error? Walk into the barbershop, go to the one that you go and talk to them, or because I can imagine some of those conversations could be easy, some of them may not go so well. So what does that look like?
I'll give you 2 examples. And I'll first start off by kind of answering your question. A community partner for me, and the way that we defined it, honestly, was there an interest and a willingness to work with people who were first members of a community that reflected where they came from and shared similar characteristics? And then was there a willingness to accept the fact that we just happened to be clinicians? Because I'd never led with, I'm Dr. Brown. I led with, I'm Italo, and I come from South Side Sacramento, California. My family's from Detroit, Michigan. That's what I led with. And then I tried to make sure that I just started with that. And that took months, just consistently reminding him that I'm just a regular person who's coming here to get edged up. And then eventually the knowledge of answering a couple of their medical questions, and then bringing forward hey, well, we actually do work like this. And then sometimes it's received very well. So I said, I'll give you 2 examples. One example was when we were first starting out in Oakland, this was a barber who had cut my friend's hair since he was probably like 12 years old. And so watching his journey and then him meeting me and seeing that there was some similarity in terms of the way we were brought up in our value systems, there was natural alignment. And so when we brought the idea of being able to host, like a New Year's Eve event there, where we were going to gauge or engage Black men and try to give them health resources on a night that could be considered very vulnerable for many people. And it worked out well, and it created the background for us to do it in that same space. But I've also had to go completely terrible. I lived in the Bronx. I trained in the Bronx, and I went into a barbershop and I tried to do the same thing. And one, as I said, they literally laughed at me for multiple times. And it wasn't a reflection of them. It was a reflection of the way that I tried to present myself. And so I think that community partners have to understand, there isn't a predatory nature in with the work that you're trying to do, and you're completely okay if they say no. I honestly respect that. And it doesn't change the willingness for me to engage you outside of that. And then I think the second part was, if there was something for them to gain, that it was never less than what I was going to come in with. I always led with resources. And I think that our group always leads with, you should have more than what we get from this process. So.
Okay, appreciate that answer. I'm going to go to Dr. Yor next and ask you about specifically your approach to coming up with research questions. Like, who defines the problem of interest? Are you looking into topics that you're interested in and then seeking partnerships in that area, or are you just looking broad and then kind of trying to fill in gaps? How does that approach look for you?
I would say that we are figuring out that process actively right now. So I think one of the things that makes the project I'm working on a little bit more complicated when it comes to engaging communities is that our community is Fresno County. It's not like one particular group within Fresno County. So, Fresno County is incredibly diverse. And we are trying to focus our vulnerability and adaptation needs assessment for the Department of Public Health on people who we know based on studies and literature are going to be more affected by climate change than other groups. Those might be outdoor workers, or people with limited resources, or people who've experienced homelessness, or older adults or youth. And they have vulnerability to climate change in very different ways. So we've started out with a collection of partners that have some connections to specific groups. And we're kind of at the stage now of planning our approach. We would like to gather a variety of perspectives from these communities that we understand to be vulnerable. And we are looking for, more specific community-based organizations that we can partner with at our next phase to actually delve into the research. So our process has been guided by a community advisory group that is also quite diverse and is meant to represent geographically and kind of thematically groups that are vulnerable and more vulnerable than the general population in some way to extreme heat or whatever the climate hazard you're talking about is. And we are listening to their input on the first part of our research, which is a collection of focus group discussions with groups, vulnerable groups in the county, and asking them, these are the topics that we would like to look at. What do you think about, the term climate change? Is that something that is talked about in your communities? How do we develop and understand, and in addition, kind of using their input to understand better from their perspectives and the communities that they might represent, what some of the issues they're facing are, and what some of the resources that they're looking from are from the county or from, you know, the state or local industries, and you know, kind of having that guide the next steps in developing our research. So that's been our approach so far. And I would say that it's been challenging, because it's like research wasn't the kind of intent going into this vulnerability and adaptation needs assessment. We're kind of layering that on, and our the group that we're working with is just very large and heterogeneous, and trying to gather many different perspectives on the issue is a challenging thing right now.
Okay, well, thank you for sharing that. And you know, I wanted to touch on something that you had briefly mentioned, and actually also get the perspective from Dr. Noroya. You mentioned community advisory boards. I've heard other names used, and some folks prefer not to use the term advisory, but I don't know, you know what's preferred currently. But in the context of coming up with research questions, Dr. Noroya, and what the problem of interest, what does it look like in from your perspective? How do you approach community members to be part of your board, and you know, how do you get them committed, and how will you know they're committed, and do you compensate them for the time that they're involved?
Okay, great question. And I think building on some of the comments already stated, I'll start a bit general and more with global health. I already recognize a few names on here that do work in global health, so hopefully it's relevant. Is that there's an aligned mission or movement currently in the global health space called the Decolonize Global Health Movement. It's a hashtag that sort of went viral on Twitter, and there are papers about it and all these discussions about how you turn that theory into actuality. But it really at the heart of it is sitting with your partner, in this case, the target population, often in a disadvantaged group, among a disadvantaged group in a low resource or resource variable context, and what we call the global south, some of the countries that traditionally have been poorer in nature. And just sitting with your partner and asking, okay, within my scope of expertise, what do you need? What is your priority? What do you think are the things that we should work on this month, this year, next year? How can we be of service? How can we be a partner, right? And I think, like I started at the top of the hour, initially it may seem, or at first glance, it may seem like the challenging option, but these people know what they want. They know what they need, and they know it better than you. And it's always reassuring and rewarding, honestly, to get the response from them. And the work has led to various different avenues, but that's the global health sort of more broad, just starting with that question when you're approaching a partner, or there's a partner of interest, or a partner who's even approached you, turning the question back around to them throughout the process of initiating on a question. For an existing team, for example, in the case of our CBPR task force, or another group I'm part of, I'm a big fan of theory of changes and guiding a team through a theory of change exercise. That's just where you draw, you through your own expertise, your own leadership, or someone who has some expertise in theory of change, you actually work with the team to walk through, just like it sounds, stepwise. Some people call them logic models, logic frameworks, piecewise. How do we get from point A, current status quo, to point B, outcome or interest or target indicator of interest for them? And then through that, you'll come up basically with a flow of a list of various interventions that you can design. And our next step has been then to do a prioritization exercise. We've used something called SWOT analysis. A lot of people I'm throwing a lot of terms out here, but hopefully, again, we can set up some follow-up as well on this. But a SWOT, strengths, weaknesses, opportunities, and threats, or some other prioritization exercise from that long list from a theory of change. And then we just go for it. As far as like actualizing methodology, haven't necessarily had the opportunity for a partner who was necessarily super research savvy, but we do present every single step of the methodology to them for feedback. We lead it kind of like a focus group, for lack of a better term. We present the proposed methodology, ask, right, what are the opportunities in this methodology or approach? What are the barriers, what are the challenges, and so on and so forth. So yeah, and again, like I said, had a lot of success with that process. So starting, like I said, open-ended with your questions, a theory of change, potentially help get consensus, and then the SWOT analysis to prioritize, and then walking them through as you go through each step of the research process. Yeah.
Great. Well, thanks so much. And, to jump on top of what you mentioned, in terms of research, historically, research, has often not benefited, and sometimes it's actually harmed the communities involved. So I think what you mentioned about involving these communities in all aspects of the research questions, every step, the research question, the methodology, the planning, the dissemination is really important. Because as we know, these communities that are impacted by health inequities are generally the least likely to be involved in the process. So thank you again for that answer. I'm going to transition now to Dr. Modi. She's going to be asking the remainder questions.
Thank you so much. So, we've heard a lot about kind of how to find your partners and how to come up with a research question. What are some, I'm going to pose this to Dr. Iswara, what are some misconceptions or challenges faced in community-based participatory research as you kind of start building those relationships and then kind of trying to help implement change or conduct your research?
Sure. So I think some of the issues we've had have just have been that we haven't experienced that traditional grant mechanisms and the way that the structures at universities and academic health centers are not really structured to allow for community engagement and achieving the principles that we're trying to achieve from the beginning. And so, like I said, we took six months to just build relationship with our community, and we wanted to be able to compensate our community members for that time that they were spending with us, right? But our grant mechanism was really only for a year, which meant 6 months of our really important, crucial time either had to happen before we were able to fund the community members for spending time with us, or we would have a significantly shortened amount of time to do the work that we wanted to do. So that was one thing. We have wanted, for example, our community, we call them community consultants in our group. We want them to facilitate our focus groups that we're having with community. And in order to do that, they need to be on the IRB. And in order to be on the IRB, they need to go to city training, which means I don't know if you all remember the city training, it's very long and convoluted and really not applicable, a lot of it, to the work that we want to do. And so that's currently been a real hurdle that we're facing right now, is trying to help our community consultants get through city training so that they can be on the IRB and so that they can really participate in the way that they want to participate. We had a lot of back and forth about including them on our IRB at all, and had to basically have the Department of Emergency Medicine hire them as affiliate staff in the department so that they wouldn't have to pay for an external IRB for Reliance to also get involved in the project. So it's little things like that where in traditional research, I think it happens much more easy. It's just not imagined for community engagement in that way. And there's been other little problems like that along the way that we've had to troubleshoot as they come. But I'm hoping will inspire the institution to really rethink how to do these moving forward to try to avoid some of these issues.
Yeah, I think, thank you for that. I think that's, the institutional research requirements are counter to what community research is. You work on all this time building the relationship and getting the trust established, and then you make them kind of do all these forms and check boxes, and it can kind of almost hinder that relationship if it's not already established. So yeah, thank you. That's really, really helpful. I also wanted to pose this to Dr. Goroya. Obviously, doing work in the international space is challenging in itself. And what are some misconceptions or challenges you have faced in that sphere with community-based research?
Yeah, no, I mean, I think Dr. Moody, you're also somewhat familiar, I know, familiar with global health as well. Well, like I said, for me, the experience overall in the end is generally a positive one. I think in the end, they're so great. I think they're so grateful when you really approach with a list, with an ear that's listening rather than just telling, which is what most people are used to, especially with academic space, like others have said. I mean, there's always the typical, apprehension about, what do you want from me? And fears and misconceptions and various beliefs, which often are, of course, founded based on historical experiences. But yeah, I mean, overall, like I said, I mean, I think it's your stance. It's managing our privilege, coin model Stephanie Nixon, managing our privilege, including in the global context. I'll give a personal example. I think Dr. Swaran and someone else had mentioned this, that perhaps, and maybe Dr. Brown had mentioned, even if you're from that community, it's realizing, yes, you may be from that community, and I'm Kenyan, for example. I do a lot of work in Kenya, but I carry a lot of privilege when I go to that community. I speak English. I'm at a certain type of institution. I'm based in the US. I have certain resources. And so I have to realize that I'm more silent in the room. I'm extremely deferent in the room. I speak last, if I speak at all. I don't speak negatively in general on people's feedback or comments. I may potentially guide a conversation or a question a certain way, but just being extremely respectful and, like I said, I think deferent and deferent in ways. Just to end, I think end with this and your and the prior question, which I didn't quite answer for Dr. Ordonez, which was the CAB, is just and how to construct a CAB or community advisory board, is just trying to be as representative as possible. And there's another paper I can share about that later, but thinking about your stakeholders, using potentially some snowballing to identify additional partners if you're feeling like the literature is not giving you the right partners, just so you're being as inclusive as possible as well in those settings.
Dr. Brown, did you have?
I just wanted to add a couple of things. One, I think that sometimes there is a notion that there is an educational gradient in these spaces. And I know, specifically speaking for the one I'm in, sometimes people believe that community members are undereducated entirely, and that may not be an accurate reflection. A variety of different people come to the barbershops. A variety of different folks have access to different health information and have varying levels of literacy. And that's something that I think, if in working in this particular population, might be taken for granted. And so that changes things. And the other thing is that needs are static. Sometimes people believe that that's the case, and they aren't. Needs can change in the middle of your project. Someone can say at one point that they needed this, and then that changed dramatically. It's something we experienced with the pandemic. Prior to the pandemic, in our barbershops, a lot of people wanted education on sexual health or wanted chronic disease stuff. And then that shifted very swiftly. And that had to change with our approach, had to change with that. So these are kind of misconceptions I wanted to bring to the table. And then the last thing I want to say is that an institution will actually understand what you're trying to accomplish. I remember when I first started my fellowship, I started in saying, hey, I'm ready to hit the ground running. Let's do this. And they were like, well, why would you focus on Black barbershops? And I said I had to go back to educating them on why this space was even important in the first place. So those are some challenges and some misconceptions that I wanted to raise.
Again, those are, I think, very valid ones too. I think the language, the literacy difference, I think that we see that in all our interactions in ED too. And it's especially in our community, you're working with very intelligent, aware people that have an insight and knowledge into the community that you do not possess. I also wanted to kind of comment on Dr. Garoya's comments about humility and kind of not necessarily being part of, like, even though you're part of the community, you still have a position of privilege. And I think that, privilege is also power in some ways. And so I think in most of these community interactions, it's extremely important to have humility and kind of be more of a fly on the wall and listen, because I think the more you talk, the more you dominate the conversation and direct it. And so kind of taking a step back and listening, which is always what we've been taught. It could be can kind of help us get this be more effective in the space. I think this was the kind of next question. I think this was the overarching thing, but why is like community-based research important to advancing health equity? What's the purpose and why does it really matter? I'm going to pose that to Dr. Yor first.
Yeah, I mean, I think there's, the mantra, nothing about us without us. When you're trying to make a difference in the lives and the health of, people from very diverse groups and people with backgrounds that are not normally represented in healthcare, you might make faulty assumptions. And so the partnership with community is really important so that people feel like they have control over the process that you're using, that they have power in the decisions that are being made in the project that you're working on, that they have a say in what the outcome will look like, that there's accountability on both sides from, the academic partner. Typically it's like one academic partner and one community-based organization, but like good communication, accountability on both sides. Often that's established when you have either a community agreement where everything is kind of written out, and people kind of agree to the terms and assign as a document that people can refer back to if the composition of either organization changes over the course of the project. And yeah, I think, everybody is well-intentioned, but just having the community voice there kind of ensures that the benefits of the project will actually reach the intended group and recipient.
Thank you. And Dr. Brown, do you want to chime in on why community-based research is helpful for health equity?
No, I thought Dr. Yor did a fantastic job. I think that the thing that stood out to me most was that it creates this system of accountability, and in a space where in a dynamic that is often driven by power, has clear, rigid walls. It helps to remove those walls. And one thing that I've seen, both up close and also at a larger scale, is you start to increase the interest of communities in this work, and they understand from a systemic and structural lens, like how they've been, discounted. That becomes a part of the conversation. And so it helps to recalibrate what that power looks like, and not only adds them to the conversation, but helps them to be better at identifying someone who's good and someone who's bad, like a good actor versus a bad actor. And I think that is extremely powerful when there's like, okay, this person's in my community, but doesn't care about me. This is a skill set they've been using since they were kids anyway, but now you're applying it to an institution that you're taught is supposed to naturally care for you, or a system that's supposed to naturally take care of you. So I think that is extremely powerful.
Looks like Dr. Goroya had a comment.
Yeah, just a quick side note or like theory brag or something you can throw in your grants or papers or whatever, is that CBPR has actually been adopted by implementation science. Like the field of implementation science, dissemination implementation science, has adopted CBPR as one of their frameworks, which is to say that if, in case you're not familiar, just to remind everybody on implementation science, it's really the science of how we implement things being usually interventions like the various ones we've heard about today. And it's not to say that, of course, people haven't been doing successful research for hundreds of years. It's a strategy to improve how we do that. It's a strategy to, as Dr. Yor said, improve hopefully our impact. Like has been said by both, to improve our level of accountability, perhaps improve the target indicators or indicators or what indicators that we choose as part of our projects, instead of sort of be slightly being off the mark. So if you think about it like that, as being mindful in our research, I think there's no reason why you shouldn't incorporate it in really most of our research today.
All right, well, I'm gonna wrap it up with one last question for all of our panelists, because we've discussed this Throughout our presentation today, the involvement of community. We've defined community. We've talked about the importance of building partnerships, building trust between community members. We've talked about what community looks like and different types of partners. How, if you have been able to, because funding is such an important aspect of doing research, how have you been able to compensate your community partners to be involved in this work if you've been able to do that? And that's open to anybody. So
I can go first. So I've had a variety of different funding over the past 10 to 15 years, NIH, World Bank, private foundation funding. And I think this question is interesting to me because well, let me back up. There was actually an announcement for NIH that I co-applied for with a community-based organization, a refugee health organization, back in the fall. If I find the link, I'll send it out. I'm not sure if it's being renewed or not. It was an NIH program. Some on the call may also know about it. But even if there's not a particular call from an organization, a foundation, or whatever else, it doesn't mean that you can't apply to the same places you would apply. This is just a methodology, or like I said, as before, a strategy that actually, like I said, you can reference all the great implementation science stuff, look that up on your own, to frame it that way. And like I said, just like we think about, just to align this to like gender-based research and how we emphasize that in all of our work, and it's almost like a checklist for a lot of our work. CBPR can be the same, and in my opinion, or community-based research should be the same. And you can put it in pretty much most projects today, arguably, in the ED.
I want to
sorry about that. Couldn't find the mute button.
Oh, you were talking.
Go ahead. Yes. No. I was trying to find the unmute button because I wanted to ask if anybody else had ideas about how they've previously been able to compensate community partners.
I was going to respond to that. I think you, in that initial needs assessment conversation, when you start to, or in that phase of initial conversations, that's something you have to bring up and try to see what they need, because, everybody doesn't want a Starbucks gift card or some type of, fixed form of payment. One thing that we learned from our partners was individuals wanted to get the cuts for free. They were like, what if I participate in what you're doing is covering the cost of a cut, which nowadays is like $50, $60. And that goes a long way because it's $60 back in the participants' pockets, as opposed to me giving you a $25 gift card. So, in that conversation, it helped a lot. And I think that the other major thing was we had a barter system essentially at one point. It didn't have anything to do with money. It had things to do with resources. So bringing in lawyers to help them figure out how to do their paperwork so they can get closer to owning their space. People who are involved in real estate that can help them figure out if they can change a location and still have the similar impact. So there's other ways to compensate the participants that have nothing to do with money, or you start by asking, what did you really need?
Okay. That makes absolute sense. And thank you for sharing that. And I think that that's, many of the examples you shared really tangible, because I think when we consider, compensating participants, kind of like are short-sighted and sometimes think a gift card may be what they need, but it could be a variety of things. And again, if we're truly involving our community partners in every step of the process, and this is equitable, the idea is we have to figure out what it is they need in order for us to, be successful at doing what we intend to. So that wraps up basically the facilitated discussion points that we had prepared for our panelists today. And we reserve some time at the end of this to open it up to questions from our participants. If there were any questions that were of interest, we'd love for you to share in the chat, and we can kind of moderate those and ask away. So I'm not sure, do we have access to allow anyone to submit chat questions? Let me double check. If not, we can kind of change that setting and go ahead and take some questions. Okay, the chat is open now. So participants, if you're interested in submitting any question, please feel free. And then we'll kind of move on after that.
While people are typing in their questions, I just wanted to point out a resource, and we can share this at the time again when we pull together a few resources as a kind of a mini toolkit if people are interested in learning more about CBPR. But there's an organization called Facilitating Power that has a document that I'm going to try to share the link for now. But it's the document is called The Spectrum of Community Engagement to Ownership. And this isn't specifically about CBPR, but I found a diagram on there very helpful. And I'm going to try to paste this in here. Okay, that's not working because it's a Google Chrome extension. But this kind of shows the continuum from of stance towards the community, from ignore to inform to consult to involve to collaborate to defer to. And then kind of defines what those mean in terms of the impact that each of those approaches can have, the community engagement goals, the message that you end up sending to the community, the types of activities that might be included in each one, and then the resource allocation from the ignore the community, which is like 100% of your project funds are allocated towards systems admin, to on the other end of the spectrum, the collaborate side is like 20 to 50% systems admin, and 50 to 70% of the resources go to the community partners. So I will try to upload the file as people are asking their questions, but from a resource allocation standpoint, I think that this really spoke to me a lot when you're trying to kind of map your own projects onto, like, you know, where would we fall in terms of the spectrum, and where we're spending our resources and what kind of message that's sending.
All right, well, thanks for sharing that. One question that I know folks have about this type of approach is, if you're interested in kind of, let's say, shifting gears into using CBPR as an approach in your research, you know, not everybody is fortunate enough to be a part of a very competitive National Clinician Scholars Program. Are there other ways to get training in this specific work and methodology?
I'll speak loosely. I think that this is something that's becoming more popular in social emergency medicine and in a lot of the health equity related fellowships in emergency medicine. If you're not directly involved with one of these research-based fellowships, you will have access to people who are, and then there's often these journal clubs or cross collaboration that you can glean insight from. That's something that I've learned. And also, I say that the national, any of the large societies have interest groups that focus on this information. Usually it's a subset or a work group or a task force that is helping to clarify this for what emergency medicine stands for and how we do it. So those are places that I think you can at least find advisors or mentors in the space to be better at it. Obviously, the strict, or I won't say strict, the framework of research is a little bit more helpful, and having familiarity with that is helpful either through another degree or something like that. But I found a lot of use just talking to people who are doing the work and then picking ideas by them and saying, hey, what do you think about this? Am I seeing this the wrong way? Because often there's a genuine nature in wanting to help you learn and help you do it the right way.
Okay, well, great. Thanks so much for that. Any questions from the participants? If not, then we'll kind of wrap things up.
I can dovetail just off of what Dr. Brown said. I agree and echo and amplify what he said about potentially either partnering or gaining mentorship from somebody on your projects, either as part and parcel of the project to kind of observe, or to ask someone to come on partially or voluntarily or however to your project to kind of guide you through the process. And I agree that it's not a huge lift, that it's something that is attainable for probably for most everyone. Yeah. The second comment is on there are a lot of implementation science training programs, like I mentioned. CBPR is one of those. For many of these programs, they will have some type of active project that you work on or that you're proposing as part of your training, and you could propose a CBPR project. I was part of the NIH one that has since been killed, but there's an NCI Training Institute. If you do cancer research, Training Institute for Dissemination and Implementation Research and Health. It's a long title, TIDIRH, NCI title. There are others. If you just Google implementation science program, there's one I think at Michigan. There's one at UW. They're kind of sprouting up all over the country. And so if that's something of interest in learning about CBPR and some other strategies on how to do things a little bit more equitably, a little bit more thoughtfully, a little more mindfully, those are some other alternatives as well.
All right. I think there's a question in the chat. Let's see here. Yep, there's a question here. So this is from Colleen Lawrence. So the question is, and she apologizes if she missed this, wondering if the panelists could comment on logistics of an approach to working with transient communities whose members may shift in and out routinely, for example, migrant laborers, IDPs. Any recommendations, anecdotes for identifying stakeholders snowball sampling in this situation? Anybody have any thoughts there?
I'll just make a quick comment. I mean, it's tough. It's not easy, but my takeaway will be this: you have to go to them frequently. You have to go to them. You have to be willing to leave the comfort of our offices and go to them, be on their level. As I think Dr. Brown said, you're going as a person, not necessarily with all your many titles when you're going to those groups, and going humbly, as I mentioned before. In our case, for the homelessness housing insecure project, we literally were sitting at some of the housing insecure organizations in the community. Like we went to them to do some of our surveys, some follow-up focus groups, and then to secure potentially some people for the community based group that would continue on with us. So I'll just kind of say that you may have to be going to parks to meet them where they're at. Community resource centers are often a good site. Yeah, just some other community-based organizations like that. Mm-hmm.
I would add in there, it's faith-based organizations still have a pretty large foothold in this space as well. Think about those as well. And I think depending upon the state that or the city that you're in, a lot of other community-based organizations have access to transient populations, and that might be a good reason to partner with them to kind of increase the catchment area or the breadth of what you're trying to do. And I think that the most difficult part is realizing that, if you are willing to pose this question, you have to also be willing to literally go into those communities and have like complete vulnerability, because what you're asking is a huge thing for them as well. And just kind of leading with that. I don't necessarily feel unsafe when I go into other communities. I try to lead with my palms open and my heart open. And so that to me is its own calling card, its own brand. So just really lean into that and expect, nothing. Expect nothing in return.
Okay, that makes sense. And I appreciate that answer. And does anybody else in the audience have any last questions? Let me see. There was a comment by Colleen Lawrence. Thank you. Love learning from everyone's perspective and experience, and I agree. If there's no further questions, then we'll we'll wrap this up here. Any last minute comments from our panelists at all? If not, then we'll kind of put this to a close. Okay. Well, I do want to thank everybody that, especially our panelists today, for providing their insights and their wisdom in the space. And I hope that this webinar proves to be just the start of a movement in building these partnerships with our communities to advance research in emergency medicine, and for us to be able to use this research to enact policy change. Because I think that's kind of the ultimate goal, so that we can have better health outcomes for our communities. And let's take this opportunity to build momentum, within emergency medicine. This is an opportunity for us to create collaboration, sharing of ideas, as many of you mentioned. And so my hope is that in the future, if we have webinars, panels, workshops at any of our national conferences, that we can also move to include some of our community partners in this conversation, so that we can get their perspectives also. I do want to let everyone know that was participating today that we will likely be sending out a follow-up survey on this webinar to get your thoughts, and also a link, which I mentioned before, crowdsourcing some resources for our participants and panelists today. So thank you again, and I appreciate you taking your time to be with us. So everybody have a great day. Thanks, everybody.
Thank you.
All right. Yep. Are we done recording? There we go. Okay. All right.
Thank
Take care,
you.
everyone.
Bye.
Bye.